Hello, everyone, and welcome to today's webinar series, Informed Feeding Choices with Dr. Diane Spatz. Before we start, I would like to review a few items so you know how to participate in today's event. You've joined the presentation listening using your computer's speaker system by default. If you would prefer to join over the telephone, just select phone call in the audio pane, and the dial-in information will be displayed. You can submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect them and address them during the Q&A session at the end of today's presentation. There is also a handout available, so please be sure to download that before the end of the event. You can locate that on your go-to panel towards the bottom. Just click on the handouts word and the links will appear. Today's webinar will be recorded and made available on Medila University and Medila's Education for Lactation Professionals YouTube channel. I would now like to introduce Dr. Diane Spatz. Dr. Spatz, PhD, RN, BC, FAAN, FAWHONN, is a professor of perinatal nursing and the Helen M. Shearer Professional of Nutrition at University of Pennsylvania School of Nursing, with joint appointment as a nurse scientist lactation at Children's Hospital of Philadelphia in the Center of Pediatric Nursing Research and Evidence-Based Practice. Dr. Spatz is the founder of CHOP Mother's Milk Bank. You can see the rest of Dr. Spatz's appointments on screen. Dr. Spatz, take it away.
Thank you. Thank you to Medila for inviting me to give this talk today. I'm sure I've met many of you in the past, and hopefully we have some new people that I have not met joining this webinar. I always have new science and new information, so I'll be excited to share that. And I've also decided to add some polling questions. So periodically through the presentation, we will be having some polls launched to ask some questions related to the content of this program. So there we go. So there I am in my cap and gown, 1995. My day today prior to coming to this webinar was meeting with 3 different PhD students, and I was helping them on their journeys to get their PhDs in human milk and lactation, and was talking to them about the fact that it's hard to believe that next year I will have my PhD for 30 years. And while I would love to say that the situation for human milk and breastfeeding has gotten better in the past 30 years for families, I am not necessarily convinced that it has. I did not set out to be a human milk researcher. I, in fact, had no exposure to human milk and breastfeeding as an undergraduate student and didn't learn about it until I became a nurse. I worked on research grants specific to human milk and breastfeeding. And then here we are almost 30 years later that this has been my science of work for now just shy of 30 years. I do this work because I believe passionately about the importance of families and babies and children. They are our future. And unfortunately, human milk and lactation doesn't get enough attention as a public health issue. So despite me working on this topic area for 30 years, we know that there's still a lot of work to be done. When I became faculty at Penn in 1995, as I had mentioned, we had not had any exposure to human milk and breastfeeding at Penn Nursing. So I said to our dean at the time, if we're going to be having a $3+ million research grant on human milk and lactation, we need to teach our students about it. And so the course that I teach at Penn Nursing has been recognized as the CDC as best practice. Now, again, think about that being almost 30 years ago. How many other programs, schools of nursing, dietetic programs, medical programs, physical therapy programs have courses or teach content on human milk and lactation? So even though we know this is a best practice, we haven't seen that schools have adopted models of educating students during their degrees with the knowledge they need to effectively help families. All of my work has really focused on thinking about how do we take that research and make sure it happens in clinical practice and that our providers know how to use the science of human milk and lactation in their clinical practices. New at Penn, as of this past year, is also a graduate level course on human milk and lactation as a public health issue, which is important because I think, as I mentioned, we still haven't seen a sea of change in current practice paradigms. My work at Children's Hospital of Philadelphia primarily has centered around the Center for Fetal Diagnosis and Treatment. So if you've heard me speak before, you'll know that my passion is surgical babies. So this child, Charlotte, has a giant omphalocele. She was diagnosed prenatally. She had two mothers who knew before she was born that she would have a difficult road and lots of surgeries. The middle picture is of her direct breastfeeding, and the right picture is of her at her 1-year-old birthday, where she received an 100% human milk diet. I apologize. My office is 90 degrees. I am going to turn on my fan in hopes that it does not interfere with the presentation. So I love human milk and breastfeeding because it can transform the lives of families. This is Charlotte and her birth mother today. Charlotte just graduated from 8th grade, healthy, beautiful, smart, no residual health problems. Her mother, based on her experience that she had with me at Children's Hospital of Philadelphia, became passionate about human milk and breastfeeding and currently serves as the executive director of the Human Milk Banking Association of North America. So we as providers make an impact on a family, not just during that short window of time when we're caring for that infant, but also for that family for the rest of their life. For the parent improves the health outcomes, not just short term for that lactating parent, but also long term into old age, impacting their heart health, their decreased risk of cancer, their decreased risk of diabetes and obesity. For the infant, we know that human milk saves lives. It reduces morbidity. It reduces mortality. And we know that there are significant costs associated with our suboptimal breastfeeding rates in the US. And what really worries me quite a bit is that we really have not been able to improve the disparities in breastfeeding in the past 30 years. We know that the health disparities from a lack of breastfeeding disproportionately impact Black families, which also impacts the pregnancy and birth outcomes. Everyone is well aware of the mortality concerns for Black women in the US. The American Academy of Pediatrics, furthermore, talked about human milk as a health equity issue. We have babies who are dying from a lack of human milk and breastfeeding. Now, when you think about breastfeeding in the Black community, we have to acknowledge and understand the significant impact of historical antecedents. We have to always be aware and mindful that women had been forced to feed other children's babies, other people's babies, their slave owner babies, while depriving their own infant. These historical factors continue to impact breastfeeding even today. We also have to acknowledge that the formula industry systematically targeted the Black community. And when you think about the OB who delivered these Fultz girls quads, right? He took over their care and he basically used them to have companies such as Gerber market their products, right? And so this is so significant because we know that the formula industry has systematically targeted African American families. Furthermore, we know that not all families have equal access to or receive equal information. So if you want to reflect on your own practice or where you live or work, have you observed implicit bias in your practice? Do you have issues of structural racism? As the CDC reports in this article I have here, there are significant disparities in terms of access to IBCLC care or access to donor milk in hospitals. They are structural factors that are impacting breastfeeding. We know that not all families are getting equal access to things like breast pumps, to IBCLC care, to home visits, to donor milk, and support services. So I really see this as a call to action for all of us, because not breastfeeding has an intergenerational impact. And this is an article from several years ago, but it was an award-winning article. And that's why I think it's so important to come back to. Because when we think about human milk and breastfeeding, people don't think of it as a primary preventative strategy, which it is. And so if we take myself as an individual, I was not breastfed as a child. So that means when I grow up, I'm at higher risk for having heart disease. I'm at higher risk for having diabetes. I'm at higher risk for having a high BMI. I'm at higher risk for having poor pregnancy outcomes because of all of my health issues that I have. So now I get pregnant and someone says to me, you should breastfeed. And I try, but these same things, my hypertension, my diabetes, my obesity, are impacting my ability to effectively establish a milk supply for my child. So now my daughter grows up with these same health problems, and it becomes a repetitive cycle. And so thinking about the importance of human milk as a potential mitigating factor, a way to change that life course or that life history. We know the benefits of human milk from a socioeconomic standpoint. Formula in the US is now very expensive, over $3,000 a year to feed your baby formula. The importance of skin-to-skin contact for that child's behavior and development for the rest of its life. And then the milk itself. right? And all the components in human milk that can't exist in infant formula. So we need to change how we think about human milk and breastfeeding as a primary preventative strategy. So many of you maybe work in baby-friendly hospitals. You're aware of the baby-friendly hospital initiative. And maybe some of you are familiar with my 10-step model. What sets my model apart is the fact that while BFHI focuses on that presumed healthy term infant, okay, it really doesn't take into account all the different things that can happen, both from an infant standpoint and a parent standpoint, that could impact someone's lactation journey. So this idea of really helping families know the science of human milk and the physiology of lactation, that's what we're focusing on today, right? Because we want every single person in our care, no matter what their age is or their skin color is, or any of those antecedents that could impact breastfeeding decisions, we want everyone to be able to make an informed feeding choice for human milk. So again, thinking about this model, it was first published 20 years ago. That's a long time ago. But is it being used everywhere? And how have people been able to use it? What we do know is that the model is stepwise and sequential. If you don't help people make informed decisions and you don't help them effectively establish and maintain a milk supply, they will never be long-term breastfeeding families. And so today, our talk is really focused on those first two steps. But what I tell every institution that I work with is that if we don't focus early on in this step 1 through 5 area, we are never going to get to do step 6 through 10. Each of the steps does have a table of evidence where we have graded the evidence, rated the evidence, updated evidence. I have quality improvement metrics that I've worked with hospitals. We have DVDs and infographics. And so I know the countries that I've worked with who've implemented my model. Maybe there are more, but I would never know about them unless they reached out to me. So do people truly make informed decisions, right? Statistically speaking, this young lady on this slide would not be a breastfeeding mom. She was 16, African American, located here in West Philadelphia, with no family history of breastfeeding at all. So all statistics would say that this would not be a breastfeeding mama. Yet this mama, who was in one of my projects, provided exclusive human milk for her child for 5.5 months. So I have 2 polling questions for you, and they will be launched. And Wendy, our assistant, is going to let me know the answers to those polling questions.
Okay, Dr. Spatz, I'm going to give you a little bit of a break here and I'll read these questions as our attendees go ahead and answer them, if that's all right.
Mm-hmm.
Perfect. At your facility, do families have to pay extra to take breastfeeding classes? I'll give everybody a few moments to answer. Just another moment or two. Okay, I think we have a good consensus. Give me just a second. And doctor, we have 21% who said yes and 79% who said no.
Okay, great. that's better than I expected, that 79% gets free classes.
Great. Shall we do the next question?
Please do.
Okay. What portion of families take a breastfeeding class prior to birth? The first option is less than 25%. The second option is between 25% and 50%. The third option is between 51% and 75%. And the final option is over 75%. And again, we'll give everybody a few moments to answer. Do you have any predictions on this one, Doctor?
I have thoughts based on research that's been conducted in the US and in other countries, and it's usually a small portion of people. So.
Perfect. We will share the response now. So the response is less than 25% is 63%.
Mm-hmm.
Between 25% and 50%, we have 27%. Then between 51% and 75%, only 7% answered. And then over 75%, we have 3%.
Wow, right? Wow. So think about this. Think about how much time people spend preparing, thinking about getting pregnant, preparing for pregnancy, preparing for birth, right? Which is only a small snippet of time. Hopefully it's 24 hours or 48 hours, or maybe if it's a really bad birth, it's 72 hours. But breastfeeding should last for 2 years. But the majority of people are not specifically getting education before birth. And some people have to pay. And this data actually mirrors some work that one of my undergraduate students has been doing with the University of Western Australia with Dr. Donna Geddes, finding that most people are not getting formal breastfeeding education and they're not learning the science. So that to me is a huge opportunity if we want to change the current breastfeeding situation. Because families are targeted by the formula industry. I am hoping now that it's 2024, most of you know about this report. But we also know that oftentimes it takes 17 years to translate research into practice. So this may be new to some of you. The report that came out in 2022 was done in 8 countries. And it's very important to note that in this report, it says that it's not the product itself that is a problem, it is how it is marketed. And so the formula industry markets people when they have an online presence that looks like they're pregnant or thinking about becoming pregnant, and they receive ads and free formula and coupons and all types of information that is selling formula as being equal to, or even in some cases superior to, human milk, right? And so if one doesn't think that their marketing strategies aren't working, all you have to do is look at this graph and these statistics, which show that while breastfeeding rates have only increased modestly in the past 20 years, formula sales have over doubled, okay? So how do people learn about breastfeeding? We just heard that a lot of them aren't taking a class, and if they are, they may need to pay some of them. Usually people get put in a box at their first visit. Maybe someone says, wow, breastfeeding is good, what should you do? Or you should do it. But what we really need to do is get rid of that box in the first prenatal visit And we need to ask families what they've heard about human milk and breastfeeding. We need to ask them first off what their concerns are. Because if they have fear of not having enough milk, or if they have fear that their nipples are going to bleed and crack and fall off, or if they have fear that their partner is not going to want them to provide milk to their baby because the breasts are for sex and not for babies, if we don't address those concerns first, they're not going to hear anything else that we say. We have to share the science, and we want to help them make an informed decision for breastfeeding in their lifestyle and for their family. And we have to use trauma-informed care, because we could have people who have experienced trauma, abuse, sexual abuse, marital abuse, who maybe would not be willing to, for example, put their baby to breast, but they would be willing to express milk and feed their baby express milk. So my argument is that prenatal consultation should be a standard of care. It should be in conjunction with regularly scheduled prenatal care. It shouldn't be something extra they have to do or on the side that they need to do. It should be with as many family persons and support persons present as desired by the pregnant person. We need to give the family jobs. We need to give them research-based education on the science of human milk. We can share the Power Pumping DVD, which is publicly available now. We want to tailor it specific to the needs of that family. We want to do a comprehensive assessment and create a sense of urgency about milk supply. So when we think about family, oftentimes in the breastfeeding literature and in breastfeeding research, it is only thought of from a heteronormative paradigm. Here in these pictures, we see moms and dads and babies and a dad and a baby. And oftentimes, people are not ever thinking about that there are other types of families than just the heteronormative paradigm. So thinking about the language that you use, using terminology that is gender neutral, talking about parents or families versus just a mother, talking about human milk versus using the term breast milk. And certainly, if a parent identifies as a mother, absolutely fine to use that language, but being mindful of how we begin our conversations with families to acknowledge that not all families are going to identify in the heteronormative paradigm. If it is a heterosexual couple, we know that the male partner is the most influential. And in 2011, in the Surgeon General Call to Breastfeeding Action, they actually recommend that interventions are targeted to fathers. But again, I want you to think about your own institution. Are you routinely including fathers in prenatal breastfeeding education? Are they present? Are we giving them jobs to do? The Association of Women's Health, Obstetric and Neonatal Nursing, who I'm a long-term member of and a fellow of, has a beautiful practice brief about the provision of human milk in the context of gender diversity. There are other resources that exist, but I can speak to this one because I was the author that wrote this for FAWHONN, and I've actually done a lot of research in the space of both same-sex mothers and also in transgender families. So this research from Europe looks at an infant feeding genogram as a tool for exploring family infant feeding history and identifying supports. And this is something that I teach all of my staff, nurses at CHOP, my students here at Penn, about the importance of that infant feeding genogram. Because if there is no lactation history, it can be very difficult for a person to both start and continue their lactation journey. Again, at my practice at CHOP, we rely heavily on involving our family members. So when we did our Pump Early, Pump Often project in our special delivery unit, this was a tool that we developed through that publication, because parents, partners often don't know what their role is. So we want to give a job to those family members. It doesn't have to be dad. It can be female partner. It can be grandma. It can be grandpa. It could be sister. But giving them specific jobs in being involved in that lactation journey. Conducting our prenatal risk assessment, okay? This is something that I have extensively been working on in the past about 5 years, because I am running into this every single day in my personal and professional life, that our families who are giving birth come with significant risk factors that could impact either coming to volume or having a complete milk supply. So prenatal risk assessment should be a standard of care, yet it is not. And so when we think about people who are at risk for an incomplete milk supply, those could be people who've had breast surgery, or people who have insufficient glandular tissue. And all of these parents are going to produce colostrum, but it's unlikely that they're going to come to full volume. And just yesterday in my personal life, I was speaking to a young lady who doesn't have any children of our own, but she heard what I did for my profession. And she says, well, can I ask you about my sister? My sister has a 2-month-old baby. She's struggling with breastfeeding. She's struggling with milk supply. What do you think it could be? So we begin to have a conversation about risk factors, about breasts that really could not make enough milk. And, I was saying to her, there is something called glandular hypoplasia, insufficient glandular tissue. It's a small portion of the population, maybe 2%. And she's like, well, what's that? And so I pull up my phone, I show a picture of this, and she's like, oh my gosh, those are my sister's breasts. That's what my sister's breasts look like. And so, she was like, I have learned so much. I'm going to call my sister right away. And so her sister was an educated woman, a pharmacist. She had prenatal care. She had postpartum care. But to date, no one had had a conversation with her. And I don't know because I haven't seen her breasts, but clearly there was something going on. And this is where I, again, go back to the fact that this should be happening prenatally as a standard of care. There are so many things that can impact effective coming to volume. And we have a new manuscript out about this topic area as a call to action, right? So if you reflect on your clinical practice where you work and you look at this large list, think about what portion of your families have one or more risk factors. And I'm going to guess it's going to be the majority. And so whether or not we have a healthy infant or one that's separated, we need to have a sense of urgency about milk production and really hone in on these people who are at risk to make sure that they're getting effective breast stimulation so that they can effectively come to volume. So these are the 2 new manuscripts. The first one about having enough milk is actually in press and available online. And it is an open access article. When I checked yesterday, it still showed up as an uncorrected proof, but I got an email last night, so it might be the final version. The second one is currently under review. This was an international collaboration of nurse midwives who really in countries outside of the US are the main provider of lactation support. You have to remember that the IBCLC profession is predominantly a US profession. 53% of all IBCLCs are in the US. Australia has the second most, but they only have a little over 3,000 IBCLCs. So in many countries, the work of lactation is being done by nurses and nurse midwives. So think about the science of human milk and whether or not you, as a healthcare provider, know the science of human milk, and if you are teaching that science of human milk to families. So I have a poll question now, which is if you ask your families when you meet them if they know what formula is made from. So Wendy's going to launch that poll. How are we doing with our responses?
Sorry about that. We are doing pretty good. We'll give it another moment.
Okay, thank you.
Any predictions on this one?
Oh, I don't think people do, but that's only based on my experience with my students and my staff here in Philadelphia.
Of course. All right, let's see. So 88% said no, and 12% said yes.
All right, well, then it's no different any place else in the world than in Philadelphia.
Correct.
And so why is that important? Like, shouldn't we be asking parents this? Parents have been marketed to think that formula is magical. Think about the formula labels that you read. They say things like neuroprotective, that they say things like reduces colic, right? They say things like it has the comfort proteins, right? So why are we not asking them what they know about formula and what it's made from? We have to help parents redefine how they look at human milk, right? Now, here's the thing, you can be formula fed and turn out okay. I'm here today, living proof Diane Spatz. She was not breastfed, okay? I was formula fed, I'm here today. But clearly I have health issues and struggles. I'm sitting here coughing because my office is 90 degrees, okay? When we think about human milk and formula, formula certainly gives a baby nutrition, but human milk is not just food, but it's also developmental and immunobiological, right? It's amazing. So we want parents to understand that human milk is a medical intervention, whether we have a sick baby requiring hospital care, or if we have a healthy baby at home. We know that human milk reduces morbidity, it reduces mortality, right? And that's both for sick and healthy babies. We also know that any human milk is good, but the longer and more exclusive human milk a baby gets results in even better outcomes, right? And so we want parents to understand the ways in which human milk is a medical intervention for their child and that dose response impact. This is one of my favorite posters from all times, which was made by one of my students at Penn for our World Breastfeeding Week celebration that we do at Children's Hospital Philadelphia. And we displayed this in the main lobby. And I just love it because it's such a beautiful pictorial about how human milk really impacts every single organ for that child, every part of that child's development. And so, one of the areas I love to focus on is to talk about the brain. Because when people have children, before they ever give birth, they're often worried about where their child's going to go to daycare, what school district their child is going to live in, so that their child has the best possible start to go to the best possible school. And then they're worried about where their child is going to go to college, right? So everyone's thinking about their child's development before sometimes they even have a baby. And so, why are we not talking about the brain and the impact of brain of human milk on the brain, right? And so, this is one of my favorite human beings of all time. This is Dr. Alan Lucas. All of you should know who he is because Dr. Lucas was the first person to randomize what preterm babies were fed in neonatal care, well before my time. And he looked at parents' own milk and donor milk, and he looked at formula. But the amazing thing about Dr. Lucas is he's been able to follow this cohort of children into adulthood. And we know that how a baby is fed impacts their brain, not just short term, but long term for the rest of your life. Now, today, in present day, it would be no longer considered ethical to randomize babies to what they're fed, but we know that not all babies are exclusively breastfed. So Dr. Sean Dione, who's from the US, has looked at the infant's brain through MRI and found that same impact of the development of the brain based on the exclusivity of human milk exposure and also the duration of human milk exposure. So again, thinking about how we're teaching families that human milk is brain power. It's brain power for their child. It's also brain protection for their child. And so this article is so important because it shows the impact for small babies, extremely low birth weight infants, of human milk on interventricular hemorrhage and periventricular leukomalacia, both which can have significant long-term developmental impact, right? And so the exposure to human milk is an independent neuroprotective effect. This is so critical for our parents to know and understand, even if they never had planned to provide milk or breastfeed for their baby. So we have 2 more poll questions. Wendy?
Perfect. Give me a moment. And there we go. Do you teach parents about the specific components of human milk and how they work? And once again, we'll give everybody a few moments. Just another moment or two, I think. And we have 46% saying no and 54% saying yes.
That's about what I thought it would be. I thought it would be about a 50-50 split. And now I'm really curious about the answer to this next one.
All right. This next question is, if you work with sick infants, do they receive 100% fresh milk diet through discharge? Not frozen thawed milk or PDHM. And again, we'll give everybody a few moments. I'm curious to hear which side you think this will fall on.
I am going to guess that most babies do not get 100% fresh milk diet from their parent.
We are so close. We'll give them another second. All right, you could not be more correct. 91% said no, and 9% said yes.
Wow, right. And so why is this so important? Okay. Now, you have to understand that this area right here about the science of human milk, I could talk to you about this for 20 days. Like, I could talk to you about it forever, but I can't because I'm on this very short webinar. So what I did is I picked my top 10 ingredients. They're no one else's top 10 except Diane Spatz's. And you can see this baby here looks really shocked, doesn't he? Because he's like, what the heck? How do parents not know about all this amazing thing and all these amazing things in human milk? Antibodies, anti-inflammatory agents, antioxidants, cytokines, HMOs, growth factors, lactoferrin, osteopoietin, stem cells, white blood cells. And let me tell you, parents want to learn about this. They get so excited knowing how their milk works. They get so excited. So I'm only going to focus on the 5 that are italicized and bolded. We can talk later about all the rest of them. Antibodies, though. Most people have heard about antibodies, right? We've heard about the enteromammary pathway. But how many times are we talking about this as a daily part of our education, right? It's why we want parents to come into the hospital. We want them to hold their babies. We want them to touch their babies. We want them to be skin to skin. When we have parents who have to put their baby into daycare, think about the germs that are in daycare. Having the parent go in and visit the daycare center before they have to put their child in daycare, right? Get colonized with what's in the baby's environment. And I think, thinking about what we've just lived through in terms of COVID, think about all the times that people were told not to breastfeed or not to do skin to skin because what if the baby might get COVID? Yet we never included people in clinical trials, and it was up to independent researchers to prove once again how powerful human milk is. So we know that the antibodies persist after exposure to COVID. We know that the antibodies persist after exposure to vaccine. So everyone should understand that human milk is absolutely robust in its ability, right, to be able to make antibodies in response to the environment. But the antibodies aren't going to be as potent in frozen thawed milk, and they're not going to be as potent in donor milk. And if we're giving donor milk, it's not going to be parent's own, so it's not going to be the antibodies targeted for that specific baby. Antioxidants are so critical. Superoxide dismutase, right? It has been shown to impact so many things. Colostrum has significantly higher antioxidants than mature milk, but mature milk is still more powerful than infant formula. And when we think about a baby who requires intensive care, oxidative stress leads to things like BPD, ROP, and NEC. And so thinking about, for example, teaching families, why do we feed colostrum first? Why do we feed colostrum in the order that it was expressed? It's because of the impact on health outcomes. We also have some really neat new research from Dr. Zarbin's group, where they've looked at the impact of dietary quality and the antioxidants in human milk, and also looked at food scores and Mediterranean diet. So the type of diet, the type of milk, the state of milk could also impact the antioxidants. And this was such an important article that was published in 2021 that showed that when we store antioxidants in the freezer, they become much less potent. right? So if you're feeding your baby only donor milk in the NICU or only frozen thawed milk, okay, which we heard that 91% of babies aren't getting that exclusive fresh milk diet, then we're not going to have the same impact on things like BPD, NEC, ROP, okay? Human milk oligosaccharides. Everyone should hopefully know who Dr. Lars Bode is. His life work is studying these oligosaccharides. Over 200 different ones that are prebiotic, probiotic, antimicrobial. They do not get digested as they go through the digestive system, and they are impacting, right, every part of that baby, right? Protecting that baby, helping that baby with his immune system, helping that baby's brain. And so, you know, why are we not teaching the parents the significant impact of these HMOs that are in human milk? Lactoferrin, multi-purpose protein, antibacterial, antifungal, antiviral, prebiotic, iron absorption. It does everything. If you would talk to Bo Lauderdale, who's out in California, Bo Lauderdale would say that lactoferrin is the most magical thing in human milk because it's impacting all the organs, right? Gastrointestinal system, the brain, the bone, all right? It is impacting everything. Now, lactoferrin, okay, similar to antibodies, if we freeze milk, its potency is reduced. And if we make pasteurized donor human milk, its potency is further reduced. So a baby's not going to get the same impact from human milk if it's not in its fresh state. Stem cells, right? Stem cells in human milk, and the fact that these stem cells can generate into whatever type of tissues that we need them to. And the fact is that we have researchers today interested in using stem cells from human milk to treat things like traumatic brain injury. Why aren't we teaching families about the significance of stem cells in the milk that, again, impacts every single organ of that child, of that baby? And parents are absolutely shocked and astounded to know that stem cells are in human milk. And they've generally heard of stem cells because some parents will pay money to bank their cord blood, right? And so they're totally surprised to learn about the presence of stem cells in human milk. This diagram here comes from an article that was published in 2021, and you can see the title about it: Anti-Infective, Anti-Inflammatory, and Immunomodulatory Properties of Human Milk. And if you look at this beautiful figure, you can see all the varied components of human milk and how they're literally impacting every single organ of that person. And some of this impact is short-term, but much of it is also long-term when we think about things like brain development and cognitive outcome. So some of you may have heard of the Power Pumping DVD, or some of you may have used the Power Pumping DVD. It is now freely accessible to anyone in the world. You can get an account with Chop Open. You create an account and log in for free, and you can access this DVD to educate your families. This is a standard part of our prenatal intervention. We also have been able to now have it translated so that there is Spanish subtitles. So again, this to me should be a standard part of our prenatal education. So I have permission to share Emmy's story, pictured here in this slide. I first met Emmy in 2011 when she was 20 years old and she was pregnant with a baby with gastroschisis. She absolutely had zero interest in breastfeeding. She told me flat out, no way, no how, not going to do it, no interest. My breasts are for sex, they're for my boyfriend. I am not going to breastfeed. And so I did her one-on-one prenatal consult, and I talked to her about the fact that we really need her milk for a baby with gastroschisis. And it was so important that her baby got human milk that if she didn't want to pump and provide milk, we would have to give the baby donor milk, because in gastroschisis, human milk can be a difference of life and death. And she said, I will pump. I hear you. I understand. I've learned so much from you. I am going to pump. And she did. She wasn't convinced she wanted to breastfeed. So fast forward to the year 2024, this young lady is in my class at CHOP, and she is now a nurse and is now a nurse in our neonatal intensive care unit. And she came up to me, and she proceeded to tell me that after me working with her, and she was actually, I should have told you this, she was in a small video we made related to the Surgeon General's call to action. You can still find it on YouTube if you want to see her, from 2011. She said to me, I went on to breastfeed my daughter for a year. I then went on to have another child and breastfed that child for 2 years. I then went on to be a surrogate for someone who couldn't have their own child, and I carried twins, and I pumped for the twins. And then I decided, I think I better become a nurse. And so she became a nurse and now works in our NICU. And you can see the quote she said, you changed my entire life, and my entire life course is what she said. And so that science really does change the life course for families if they understand. So we do a modified version of the centering model at CHOP. If you are a midwife or you know midwives, you probably are familiar with the centering model. It changes outcomes. For us, we wanted to see if our centering model improved lactation outcomes. So we looked at a cohort of families who participated in our Mama Care at CHOP, which is a modification of group prenatal care. And not all of our families, as I mentioned, come with prenatal intent. But as you can see, 100% of participants who participated in Mama Care initiated pumping or breastfeeding, and 87% did so through discharge. So these rates are higher than breastfeeding rates for even healthy term babies. We also published about our tailored prenatal intervention, and you can see here in this slide that our breastfeeding outcomes were higher at all time points compared to national data and Pennsylvania data. And impressively, over 30% of our families provided milk for over a year, and there's not any national data to compare that to. So how we teach our families makes a difference. So lastly, I'll just share about the new study that is happening in the United States, which is initiated through Congress and carried out through the National Academies of Science, Engineering, and Medicine. I am serving as a member of this committee. It's such important work because, as I said when I was being interviewed for the job, we actually know a lot about the research and the science that we should be doing to help people have good lactation outcomes. We just either choose not to do it or use it, or we choose not to fund it. And so this is an important analysis that's ongoing with a report that will come out in 2025. In closing, I'd like to have you consider joining me in Charleston this December for the International Society for Research in Human Milk and Lactation Conference. This is the world leading scientists in human milk and breastfeeding. And it's the first time the conference is going to be held in the US in over a decade, because we're an international organization. So it has been mostly held abroad. So the information is there. There's a little QR code. And I maybe left 1 minute for questions.
Dr. Spatz, I don't know that we've left any time for questions, but your content was far more important. We do apologize. We're not going to be able to address the questions, but we will address them in email following the event. And so we'll gather those and provide responses after the fact. So thank you, Dr. Spatz, and thank you everyone for attending today's webinar, Informed Feeding Choices. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. On behalf of Medela and Spatz, thank you so much for joining us today, and have a great rest of your afternoon. Thanks, Doctor.
Thank you.